Hello, I'm Michael Feldman, and I'm the Medical Director of the Evans-Haynes Burn Center, which is part of the Virginia Commonwealth University in Richmond, Virginia. We're proud to bring you this talk on pediatric burn care. We'd also like to thank you for attending the Panamerican burn course. Learning points for this discussion include how burn alters normal physiology for children, how has pediatric burn care changed over the last 50 years, how do you approach pediatric burn resuscitation, as well as a discussion about modern pediatric burn reconstruction and learning about optimizing pediatric outcomes for burns. What makes a burn a burn? Well, a burn injury is not just skin deep. The effects of a burn can depress cardiac output, increase peripheral resistance, and lead to a capillary leakage, which makes fluid management difficult. In addition, burns cause a hypermetabolic response. This can lead to the loss of lean body mass and increased nutritional requirements. All of these are dependent on the size of the burn. The larger the burn, the more robust these effects. In addition, there are psychiatric needs for burn patients with severe burns that can be quite cumbersome. What's new? Well, burn survival has been improving since the 1950s. This is due to a number of things, including better critical care, early excision of burn wounds, a focus on early nutrition, a better understanding of fluid resuscitation, maintaining normothermia, and addressing the hypermetabolic demand. Burn survival is shown by the Bow score. This typically, in the past, had been a one-to-one relationship between age and total body surface area. In other words, a 50-year-old person with a 50% burn had 100% mortality. Nowadays, a Bow score of 100 has a relatively good chance of survival and making it to rehabilitation. Here, I'm showing you the revised modern Bow score, which is not a straight linear relationship between age and total body surface area of burn. The presence of inhalation, however, does significantly increase one's Bow score. Patients can be salvaged, so to speak, up to a Bow score of 150. Obviously, understanding the extent of the burn is very important. People tend to overestimate burns, and that can lead to problems like over-resuscitation. There are adjuncts to help figure out the size of a burn, such as the SAGE diagram, which is an online program that presents a two-dimensional picture of the child that one can draw on, and it'll calculate the total body surface area and help with fluid management. More quick methods for determining burns can include the rule of palms, which is the child's palm plus fingers is 1% of their surface area. An even more accurate method is the London-Browder chart, which requires one to have access to this chart and calculate surface area in that method. Once the size of the burn is calculated and the weight of the child is known, the practitioner would calculate their burn resuscitation. We prefer the consensus formula. This is 3 mLs times weight in kilograms times total body surface area. Now, they're multiplied together, so it's not multiplying by 0.3 for a 30% burn, but by 30. This would be given as lactated ringers, with half given over the first 8 hours and presumably the second half over the last 16 hours. This change in the rate of the fluid is due to capillary leakage. Early in the resuscitation, the patient may need more fluids because of the capillary leakage phenomenon, which eventually seals and allows one to decrease fluid rate. One would not automatically decrease the rate, but would instead adjust the rate based on urine output. These patients need a Foley, and they need hourly urine output measured to determine how to adjust their fluids. Young children, in addition to the consensus formula resuscitation, also receive maintenance in the form of D5 lactated ringers, as they will use up their dextrose stores very quickly. For children who don't respond to crystalloid after the first 8 hours of the burn, we'll put them on an albumin drip, which we run as 5% albumin at 1 ml per kg per hour, and don't titrate, as the lactated ringers remains titrated to urine output. We prefer to use burn resuscitation for children with burns of 10% or more. We follow urine output hourly, as I discussed, with a goal urine output of 1 ml per kg per hour. Here's an outline of our resuscitation guideline. You can see centrally, if they're meeting their urine output goal, the lactated ringers rate stays the same. If it's too low, they'll titrate up by 10%. If it's too high, they'll go down by 10%. This is done every hour until resuscitation is complete, which can be 24 to 48 hours from the burn. It is as important to reduce the rate as it is to increase it, as too much fluid can be as detrimental as too little fluid. This is our guideline in totality, showing the practitioners how to start resuscitation and reminding them that they need to contact the burn surgeon if the patient makes no urine or has a low urine output for 2 consecutive hours. This also has the albumin resuscitation and rescue protocols in place in the bottom left. For patients who are over-resuscitated, you risk problems like pulmonary or cardiac edema, as well as compartment syndromes. Here we're showing a patient who has an abdominal compartment syndrome, which is being addressed through an exploratory laparotomy. The abdomen needs to be left open, and this is the only way to address this issue. If this happens, the mortality is quite high, and we work to avoid this situation in the first place. One must recognize that the patient is not responding to fluids, and instead of continuing to use fluids and escalate the fluids, consider changing to dialysis and pressors and reducing fluids in this particular situation. Later in their course, burn patients can become quite ill from infection. This is due to the loss of their normal skin barrier to bacteria. Burn patients are already febrile and already tachycardic, so it may be difficult to identify early sepsis in pediatric burns, although early identification improves outcomes. One does not use prophylactic antibiotics in pediatric burns, as this can worsen outcomes. Sepsis, on the other hand, may account for upwards of 55% of pediatric burn deaths. So how do we recognize burn sepsis in children? Well, there are a number of parameters. Watch for progressive tachycardia greater than 2 standard deviations for their age, the same for tachypnea, or thrombocytopenia less than 2 standard deviations for their age. In addition, one may see hyperglycemia or the inability to tolerate enteral feeds. Inhalation injury is important to diagnose for this population, as it will increase mortality and increase fluid requirements. Here we're showing a bronchoscopic examination with carbonaceous sputum at the level of the carina, as well as erythematous mucosa. We treat this by alternating nebulized albuterol, heparin, and mucomist every 4 hours. We have a low threshold for securing the airway. Adjuncts to ameliorate the hypermetabolic demand include 2 drugs, oxandrolone, which is an anabolic steroid, and propranolol. These have been studied mostly by Dr. Herndon, whose burn group operates out of Texas. He created a double-blinded, placebo-controlled trial with twice-daily administration of oxandrolone versus placebo. This was done in the early 2000s for children with large burns. The oxandrolone was dosed twice a day and was carried on for a year. They measured outcomes at 6, 9, and 12 months, measuring lab studies, as well as resting energy expenditure, and completed questionnaires looking for side effects of the oxandrolone. The groups were equal, with no statistically significant differences. They showed improvement in both lean body mass as well as bone mineral content. Oxandrolone had shown no excessive hair growth or precocious pubertal development, although 2 female patients had clitoromegaly. It is unclear if this is due to their perineal burns. There was no noted change in hepatic function either. The second study on propranolol looked at this very commonly used beta blocker in children. The hypothesis was that this may reverse the catabolism of severe burns in this patient population. This was also studied by Dr. Herndon and his group in Texas and published in the New England Journal of Medicine in 2001. The idea was that beta blockade may reduce the myocardial work, lipolysis, and negative nitrogen balance without negatively affecting cardiac or metabolic function. They looked at 25 children, all with large burns, that were randomized to either receive oral propranolol or control. The dose of the propranolol was adjusted to decrease the resting heart rate by 20% from baseline. The groups were similar, with no statistically significant differences. They were able to show that the propranolol had a reasonable effect without causing hypotension. The propranolol group had a significant reduction in loss of lean body mass. They were able to show that there were no real adverse events, although they did have to temporarily hold the propranolol dose in 3 of the 13 patients. Overall, they showed an improvement in net muscle protein balance and increase in lean body mass of these patients. Going on to burn wound management, early excision, while it may increase blood loss, can lead to decreased length of stay and decreased infectious risk. One must keep the patients from getting hypothermic. Early excision may help with fluid shifts, as well as decrease electrolyte abnormalities. This can decrease pain and anxiety with earlier wound healing. Always consider airway concerns with trips to the operating room and anesthetic concerns, as propofol may vasodilate and cause hypotension. We consider the use of ketamine and Precedex as an adjunct. Hypothermia can affect every system in the body. This can lead to problems like coagulopathies, reduced cardiac output, and even immunosuppression. We work very hard to keep the patient warm using multiple modalities. We'll increase the thermostat, use radiant heat warmers, underbody fluid warmers, as well as forced air warmers. As you can see, there are multiple adjuncts at work in this picture. Burn wound management can be through the typical dressings. This could be with silver or silicone or even negative pressure therapy. We'll bring into bear biologics like BioBrain and Integra, which are discussed in detail in a different lecture. Burn scar management should be early if it has a functional effects or is affecting growth. We'll use multiple modalities, including laser treatment, compression therapy, surgical releases, including skin grafts if necessary, and/or tissue expansion. Long-term quality of life is possible with modern medicine. This includes the use of early psychological intervention, both for the caregiver and the patient, with treatment and hard work and rehabilitation that focuses on pain control and anxiety management, as well as bringing to bear modalities that help the patient to take care of themselves and their family, such as prosthetics, we can accomplish much. The future of pediatric burn care is wide open. This may include the use of enzymatic debriding agents that could decrease the need for a knife to perform debridement. It could use spray-on cell technology and even stem cell technology in the future. Thank you very much for listening to our talk on pediatric burns. Thank you for attending the Panamerican Burn course.